And a lot has changed since the 1970s. This is for all cancers. Death rate for cancers in the United States have dropped 22% for men and 14% of women just since 1990. In 1975, only 50% of the people diagnosed with cancer could expect to live another 5 years. Today, it's more than 70%. Among children, and we know this through ALL, 80% can now expect to survive, compared to only 52% in 1975. Now, much of that success can be attributed to two key milestones in cancer research. Number one, there's a better understanding that lifestyle factors can contribute to cancer. Don't smoke. We all know that. The second one is the mapping of the human genome. It's our heredity information that took place in 2001. Coincidentally, just a few years prior to that, in 1998, the Leukemia Research Foundation funded a new investigator at the University of Washington named Marshall Horwitz. Dr. Horwitz was interested in inherited disorders in leukemia. What is our impact? Well, just recently, Dr. Horwitz and his colleagues in Australia identified a new genetic defect that predisposes people to AML and myelodysplasia. Take a moment to read the center spread in your programs at your tables today. There's handouts as well about Dr. Horwitz's work, and we urge you to take this home with you to learn about it. This is big news. This is what we do at the Leukemia Research Foundation. 13 years ago, we funded Dr. Horwitz's work as he got started. Today, he reports on a major discovery in the fight against blood cancers. We help new investigators progress in their projects to qualify for major funding from the National Institutes of Health or other larger organizations, so that those projects that they get started with can accelerate our pursuit of a cure and lead towards major discoveries. This is impact, and this is what we do. To tell you more about his work and exciting findings, please welcome from the University of Washington Medical Center, Professor Marshall Horwitz.
Well, thank you very much for inviting me to be here. This is a very humbling experience. It's almost like my bar mitzvah in many ways. In fact, as I look out through the room, I think I even see some people who maybe are more distant branches of the family, who maybe even were at my bar mitzvah. I'm not totally sure on that. I also have to make a disclosure in the interest of full information that there's an ulterior motive that brings me to Chicago as well, and that I'm pleased to say my son Noah has just started a doctoral program in chemistry at Northwestern. So only too eager to come out to Chicago for a visit, and I hope to be a more frequent visitor in the future. You know what I think is one of the driving forces, there are several driving forces for why we all work in the laboratory and try to determine the causes of leukemia. The first is, for those of us who are clinically involved and for those of us who aren't, it's thinking about the patients and the prospects for improving therapy and outcomes for leukemia that really drives us forward. But equally important and very heartwarming to see is the support from you all, from family members and other volunteers, people who really dedicate their efforts towards moving the field forward and helping patients. I'm really appreciative for that, and it's a very heartwarming experience, I have to tell you, to be here amongst you, and I appreciate that experience very much, and I appreciate all that you do. So I'll tell you what the Leukemia Research Foundation funding meant to me. I received an award in 1998. It was a relatively small amount in comparison to the types of awards that the NIH distributes for research grants. Nevertheless, actually, the Leukemia Research Foundation awards have increased in size since that time, and the NIH funding has remained relatively static in recent years. There have been substantial cuts in the awards, so the LRF for current recipients is relatively even greater impact than it was for me back in the day. And at the time I wrote the grant, you know, you always have to promise the moon and the stars, and I wrote it, you also have to be realistic as well, and I wrote it using the most optimistic projections I could make, that we could find a gene that predisposed people to development of MDS and AML. And of course, within the short time frame of 1 or 2 years that the grant support provided, I didn't accomplish that goal, and I always felt a pang of conscience that I received money and I didn't succeed in doing what I had set out to do. Yet, nevertheless, we inched forward closer to that goal. And it's taken nearly 20 years to accomplish the task. I first got interested in the field in 1992 when I saw a patient who was at the University of Washington and Fred Hutchinson Cancer Research Center in Seattle. She was a 21-year-old woman who was in the second trimester of her pregnancy, and she abruptly presented with AML. And I was interested in human genetics, and so I was consulted because it was known that she had a family history of 6 other people in her family who had MDS and or AML, and interestingly enough, another member of her family who didn't have leukemia but who died from an overwhelming infection related to TB, an infection that at the time only AIDS patients got, and she was not somebody who had HIV. So I thought that was a very compelling project to work on, that there must be a gene here, and in a certain proportion of patients who have MDS and AML, there is a gene that's responsible. Most of the time that people develop cancer, what we inherit genetically from our parents has only a relatively small impact on risk predisposition. Most of the time, cancer occurs sporadically as a consequence of things we may have been exposed to in the environment. Tobacco smoke is one, but probably more often just as a result of bad luck, because every time the cells divide, they have to replicate their DNA, and every time DNA has replicated, mistakes are invariably introduced into the genome in the form of mutations, and if those mutations arise in an important gene, then cancer is the consequence. But yet, in a few patients with cancer, there are people who inherit their risk predisposition as a consequence of a single gene. Some of the best known examples are for breast and ovarian cancer, where the BRCA1 and BRCA2 genes account for a definite proportion of cases. And there are founder effects in certain populations, including the Ashkenazi Jewish population. And it's true for almost any type of cancer, leukemia included, that there are people who seem to inherit their risk predisposition from birth with the flip of a coin, a 50-50 transmission. And that's what we found. We, over the course of the years, and using the LRF money that I had in the early phase of my career, I set out to collect these families, perform initial genetic studies using the technology that was then current 10 years ago, which is now hopelessly obsolete by today's remarkable technological standards. And we set out over time and worked towards finding the gene. And as we heard from Maureen Hoggins earlier, it takes a village to care for leukemia patients. It also takes a village to do research, in this case, a global village. So our research is, first of all, built on the foundation of work that lots of other people did, but in particular, I have to thank my colleague in Adelaide, Australia, Hamish Scott, who did the lion's share of the molecular work involved in finding these mutations. So we found a gene It's called GATA2, G-A-T-A-2. It's actually the third gene that's been found to be associated with hereditary risk to AML and or MDS. The other two seem to account for only a small proportion of cases, and GATA2 seems to be a major one in that literally patients and their families have been coming out of the woodwork since we first reported these results back in December at the American Society of Hematology meeting in Orlando. And it's a very pleasing discovery to make because it connects AML and MDS to other types of leukemia. In particular, John Crispino showed that GATA1 was frequently mutated, not at birth, but an acquired mutation in individuals who have Down syndrome who develop leukemia. And our gene, GATA2, is a relative of GATA1, and it has very similar function and works very closely with GATA1, so we can build on the foundation of research that John and his colleagues have been doing in order to help further the understanding. Moreover, since we found the gene, we've come to appreciate that mutations in GATA2 can occur in non-hereditary forms of leukemia, and that it's associated with transition of CML to the accelerated blast crisis phase. And so the discovery immediately provides another clue as to the processes that lead to the development of leukemia by associating it and placing it in the framework of other types of leukemia. It'll take a long time to translate those advances, or at least I think it's going to take a long time to translate those advances into something that has immediate clinical relevance, but there are some things we can do with it right away. The first thing is that while the majority of people who develop AML or MDS don't get it as the result of a hereditary predisposition, for those who do, we now have a test to identify those people who are at risk. And although that may be disconcerting news to be tested and to find out that you have a risk for AML or MDS, it can also be useful information in appropriately choosing a bone marrow donor, given that the most successful transplants, or the first place you look for a transplant, is amongst a sibling who's HLA matched, as you all well know, and it would not be good to put in a marrow that has the propensity to also develop leukemia. The second way it's proved immediately clinically beneficial is that there's really been an explosion of clinical knowledge about the features of the clinical syndrome of GATA2 mutations. There's a large group at the NIH with whom we work closely that had previously been collecting families who had a mild immunodeficiency component, who were at risk for getting severe bacterial infections, bacteria very much related to TB, and also severe viral infections. And it was very surprising to find out that we were looking at different ends of the elephant, so to speak. And so now we know that there are a range of problems that people with GATA2 mutations experience, including predisposition to severe infections. So having that information on hand helps us understand better how to stay on top of those infections, even amongst family members who don't have MDS or AML. So, you know, putting it all together, I don't want to hype or overplay the significance of this finding. It's a small step. It's one in many clues that we have towards the development of leukemia. You know, I just can't express my gratitude sufficiently to tell you how important the LRF money was. There were points in my career when submitted NIH grants and didn't get it, and thought about quitting or moving in a different direction, and having that funding at a very pivotal point during my early career of development was incredibly important in keeping the fire going and staying committed to this. And so, once again, I'd say thank you very much.